Welcome to StudyNeuro. In this session, we will explore craniopharyngioma, a tumor that arises in the cellar and suprasellar region of the brain, near the pituitary gland and optic pathways, where even small growths can affect vision and hormone regulation. Join the StudyNeuro community for high-yield neuroscience education and clinical pearls. You can find us on YouTube and Facebook at StudyNeuro, and on TikTok, Instagram, and X at StudyNeuroOfficial and StudyNeuro 2025. By the end of this presentation, you should understand the pathology and origin of craniopharyngioma and recognize the differences between the two major subtypes, Adamantinomatous and Papillary. We will also review key imaging features, genetic changes, epidemiology, and current treatment approaches that influence patient outcomes. Craniopharyngioma is a rare epithelial tumor that develops in the cellar and suprasellar region of the brain, an area located just above the pituitary gland and close to structures that control vision and hormone balance. It grows outside the brain tissue itself, which is why it is described as an extraaxial tumor. The tumor arises from embryologic tissue left behind during early development. These tissues come from Rathke's pouch or the craniopharyngeal duct, structures that normally help form parts of the pituitary gland during fetal life. This tumor was first described in 1857 by Friedrich Albert von Zenker. His observations helped identify unusual squamous-like epithelial cells within the pituitary region, which later became recognized as the basis of craniopharyngioma. Despite being classified as benign under the microscope, craniopharyngiomas often cause significant clinical problems because they grow next to important brain structures, including the optic pathways and the hypothalamic pituitary system, where even gradual pressure can disrupt vision and hormone regulation. Location matters more than histology here. The tumor may appear harmless in tissue sections, yet its slow expansion can compress nearby structures and lead to neurological symptoms as well as endocrine dysfunction. The origin of craniopharyngioma remains an area of study. The exact process that leads to tumor formation is still not completely clear. Researchers generally describe two main explanations for how these tumors begin. One explanation is the embryonic theory. This theory proposes that the tumor develops from small pieces of tissue left behind from Rathke's pouch, an early structure that forms part of the anterior pituitary during fetal development. During this developmental stage, ectodermal cells may persist around the pituitary region, and in some cases, these squamous epithelial cells later undergo abnormal growth and transformation, eventually forming a tumor that is most often seen in children. Another explanation is the metaplastic theory. This theory suggests that normal cells of the anterior pituitary, particularly those in the pars tubularis, gradually change their cell type through a process called squamous metaplasia. These transformed epithelial cells can form small nests within the pituitary tissue, and over time, as these cell clusters increase with age, they may give rise to papillary craniopharyngioma, a subtype more frequently observed in adults. Craniopharyngioma is classified as a benign brain tumor. Under the microscope, it appears low-grade, and the World Health Organization places it in grade 1. This means the tumor cells grow slowly and do not show the aggressive features typical of high-grade malignancies. Despite this classification, two distinct biological forms are recognized. These are the Adamantinomatous type and the Papillary type. Each form behaves somewhat differently in patients. The Adamantinomatous variant tends to appear more often in children, while the papillary form is usually seen in adults. And although both arise in the same cellar and suprasellar region, their imaging patterns, microscopic structure, and genetic changes show clear differences. These differences matter clinically. Understanding the subtype helps guide diagnosis, interpretation of imaging, and future approaches to treatment. Epidemiology describes how often a disease occurs and which groups are most affected. For craniopharyngioma, the tumor is uncommon, but it remains clinically important because of its location near structures that control vision and hormones. Overall numbers are small. Craniopharyngioma represents about 1 to 4% of all brain tumors, and population studies estimate roughly 0.5 to 2.5 new cases for every million people each year. The pattern looks different in children. In pediatric populations, craniopharyngioma accounts for a noticeable share of brain tumors, roughly between 3 and 13%, and it is among the most frequent tumors arising in the sellar chiasmatic region. Age distribution also follows a recognizable pattern. The Adamantinomatous subtype shows 2 peaks of occurrence, one during childhood, usually between 5 and 15 years, and another in middle adulthood, around 40 to 55 years. The Papillary subtype, in contrast, appears almost entirely in adults and is most often diagnosed during the same middle age range. This pattern is distinctive. It helps guide clinical suspicion. Adamantinomatous craniopharyngioma is one of the 2 main subtypes of craniopharyngioma. It is classified as a World Health Organization Grade 1 tumor, which means the tumor grows slowly and is considered benign, although its location can still cause serious clinical problems. This subtype appears most often in children. It represents the dominant form of craniopharyngioma in the pediatric age group. Pathology shows a distinctive structure. The tumor commonly contains both solid tissue and cystic spaces, and under the microscope, the epithelial cells often line up in a palisading pattern along the edges of the tumor nests. Another feature stands out clearly. Pathologists often see areas of so-called wet keratin, which refers to compact layers of keratin debris that accumulate within the tumor and form irregular masses. Some regions also resemble the stellate reticulum, a loose network of star-shaped cells that look similar to tissue seen during early tooth development, while the cystic spaces frequently contain thick fluid rich in cholesterol crystals. These findings together form the classic microscopic picture.
Adamantinomatous craniopharyngioma, or ACP, is a type of brain tumor that often appears near the pituitary. At the molecular level, most cases, about 95%, show a mutation in the CTNNB1 gene. This gene makes a protein called beta-catenin. Mutations usually happen in exon 3, which turns on a signaling pathway called WNT/beta-catenin. This pathway controls cell growth, and when it's active in the wrong way, it can drive tumor formation. The age at which ACP shows up has 2 peaks. Children between 5 and 15 are most commonly affected. Adults from 40 to 55 can get it too. The tumor usually grows in the sellar or suprasellar region, right next to the pituitary gland. Less often, it can appear purely inside the sella or in the third ventricle. Rare cases do show these unusual locations, but that's not the norm. Imaging often helps confirm the diagnosis. Most ACPs have cystic areas, fluid-filled pockets inside the tumor. Calcifications are another clue, tiny deposits that show up on scans. The cyst wall often lights up after contrast. There's a handy 90% rule. About 90% of tumors show at least 2 of these features. Remember, this isn't always the case, but it's a strong guide for radiologists.
Papillary craniopharyngioma is a benign brain tumor that develops near the pituitary gland. It is classified as a World Health Organization Grade 1 tumor, which means it grows slowly and usually does not spread to distant areas. Even so, its location near critical brain structures can still cause important clinical problems. Under the microscope, this tumor shows a distinctive tissue pattern. The lining is made of squamous epithelial cells, which are flat cells that form protective layers in many parts of the body, and in this tumor, they grow into papillary folds that contain a central core of small blood vessels. These fibrovascular papillary structures are a key feature, and they give the tumor its characteristic branching appearance when examined with histology. On imaging and pathology, papillary craniopharyngioma usually appears as a solid mass rather than a fluid-filled one. Papillary craniopharyngioma has a distinct genetic driver. In many cases, the tumor carries a somatic mutation in the BRAF gene, most commonly the V600E variant. The BRAF gene normally makes a protein that helps control signals inside the cell that guide growth and survival. When the V600E mutation appears, that signal pathway becomes abnormally active and can push cells to keep growing. This mutation is very common.
Studies show that roughly 81 to nearly 100% of papillary craniopharyngiomas carry this BRAF V600E mutation, which then activates a signaling route known as the MAPK pathway, a pathway that normally helps cells respond to growth signals but can drive tumor formation when overactive. This discovery has clear clinical value. Because the tumor growth depends on this altered BRAF signaling, targeted drugs can sometimes block the pathway and slow tumor activity. Some patients have been treated with BRAF inhibitors or related MEK inhibitors, medicines designed to shut down the abnormal signal created by the mutation. Vimirinib is one example.
Craniopharyngioma often produces symptoms because it sits close to critical brain structures and slowly increases pressure inside the skull. Increased intracranial pressure means the pressure within the closed space of the skull rises as the tumor grows or blocks normal fluid movement. Patients usually develop headache, nausea, and sometimes vomiting. These symptoms tend to be worse in the morning, when pressure inside the head can temporarily rise during sleep. Morning headaches are common. Vision problems are also frequent because the tumor grows near the optic pathways. The optic chiasm is the crossing point where visual nerve fibers from each eye partially switch sides, and when this structure is compressed by a nearby mass, patients may develop blurred vision or double vision. In some cases, a very characteristic defect appears, called bitemporal hemianopia, which means loss of vision in the outer halves of both visual fields. Hormonal problems occur when the tumor affects the pituitary gland, a small endocrine organ that controls hormone production throughout the body. Damage to this gland can lead to several hormone deficiencies, and the effects vary with age and with the specific hormone involved. Children may develop slow growth or delayed puberty, while adults often report fatigue or weight changes, and some patients develop diabetes insipidus due to disruption of normal water balance. Hormonal effects are often significant. Next to the pituitary lies the hypothalamus, a brain region that regulates appetite, behavior, and several autonomic functions. When this area is involved, patients may show appetite changes or problems with memory and personality, and these effects can gradually make daily functioning more difficult over time. A few other features can appear in some patients. If the tumor blocks the normal flow of cerebral spinal fluid through the ventricles, fluid can accumulate and produce hydrocephalus, which further raises pressure in the brain. Seizures may also occur, though this is less common. These complications are uncommon but important. Neuroradiological imaging plays a central role in the evaluation of craniopharyngioma. Computed tomography, often called CT, is a scanning method that uses X-rays to create detailed images of brain structures. It is especially useful for detecting calcifications, which are small deposits of calcium that appear very bright on CT images. CT is very sensitive for this feature. In Adamantinomatous craniopharyngioma, imaging often shows a cystic mass located in the suprasellar region, the area just above the cella where the pituitary gland sits. The cystic part usually appears hypodense on CT, meaning it looks darker than the surrounding brain tissue. Calcifications are frequently present, sometimes within the tumor itself and sometimes along the wall of the cystic spaces. Papillary craniopharyngioma has a somewhat different appearance. This subtype usually forms a more solid mass in the suprasellar region. On CT scans, it often appears isodense, which means the tumor density looks similar to the surrounding brain tissue. Calcifications are uncommon in this form. Magnetic resonance imaging, or MRI, provides another layer of detail. MRI uses magnetic fields and radio waves to generate high-contrast images of brain tissue, which allows better evaluation of tumor composition and its relationship to nearby structures. MRI gives better soft tissue detail. In Adamantinomatous craniopharyngioma, MRI often shows a cystic lesion that may be unilocular or multilocular, meaning it can contain one fluid cavity or several connected cystic spaces. Small solid nodules may appear within the cysts, and the signal intensity on T1 images can vary depending on the protein or cholesterol content of the cyst fluid, while T2 images often show mixed areas of lower and higher signal. Papillary craniopharyngioma tends to appear more uniform on MRI. The tumor commonly shows signal intensity that is similar to or slightly lower than normal brain tissue on T1 weighted images, while on T2 weighted images it often appears brighter, though small focal areas of lower signal intensity may still be present within the lesion.
Treatment of craniopharyngioma requires a coordinated clinical approach. The tumor often affects structures that control vision, hormones, and brain regulation, so care usually involves specialists from neurosurgery, endocrinology, and ophthalmology. These teams work together to plan treatment and long-term monitoring. Management is multidisciplinary. Surgery remains the main form of treatment. The goal is maximal safe tumor removal while protecting nearby critical structures such as the optic chiasm, the hypothalamus, and the pituitary stalk, which sit very close to the tumor and can be easily injured during aggressive resection. In some patients, surgeons attempt gross total resection, which means removing the tumor completely in order to lower the chance of recurrence. In other situations, subtotal resection is chosen when the tumor lies next to sensitive brain regions. This approach leaves a small portion behind and is often followed by radiation therapy. Different surgical routes may be used. Many tumors in the sellar region can be reached through an endoscopic endonasal or transsphenoidal approach, where instruments pass through the nasal cavity to reach the tumor. Larger or more complex lesions may require a transcranial operation, which allows wider exposure of the surrounding brain structures. The approach depends on anatomy. Radiotherapy plays an important supportive role. It is commonly used when small tumor remnants remain after surgery or when the tumor grows again later. And modern radiation methods can deliver focused energy while limiting injury to nearby brain tissue. Techniques such as intensity-modulated radiotherapy, stereotactic radiotherapy, and proton beam therapy allow doctors to concentrate radiation within the tumor while reducing exposure to the optic nerves and surrounding brain. Medical and supportive care are also important because many patients develop hormonal problems after tumor growth or surgery. The pituitary gland regulates many body hormones, so damage to the system can lead to deficiencies that require replacement therapy. And patients may need treatment for diabetes insipidus, electrolyte imbalance, or hypothalamic weight changes. These problems can significantly affect daily life. Long-term follow-up is essential. Patients usually undergo regular MRI scans to check for tumor recurrence, and ongoing endocrine and visual assessments help clinicians detect complications early and adjust treatment when needed. Monitoring continues for many years, sometimes for life.
After surgery for craniopharyngioma, several complications can arise. Neurological issues are common and include cerebral spinal fluid leaks, where the fluid surrounding the brain escapes through the surgical site, sometimes leading to infection. Hydrocephalus, which occurs in about 15 to 18% of patients, is a buildup of fluid in the brain's ventricles that can increase pressure and require intervention. Meningitis, an infection of the brain's protective layers, occurs less frequently, roughly 6 to 12% of the time, but can be serious. Vision problems are another concern. Many children, almost half to 3/4, experience persistent visual deficits after surgery, often due to the tumor's proximity to the optic nerves and chiasm. These deficits can range from mild visual field gaps to more significant impairment, and they may last long-term despite successful tumor removal. Endocrine complications are particularly common, reflecting damage to the pituitary and hypothalamus. Panhypopituitarism, or complete loss of pituitary hormone production, occurs in around 63% of patients. Diabetes insipidus, a condition where the body cannot properly regulate water balance, affects roughly 46%. Hypothalamic obesity, caused by damage to the brain region that controls appetite and energy use, develops in 40 to 80% of patients and can significantly impact quality of life. These complications highlight the delicate balance required during surgery, removing the tumor while preserving critical neurological, visual, and hormonal function. Careful postoperative monitoring and long-term follow-up are essential to manage these outcomes. Prognosis after craniopharyngioma surgery is generally favorable, but risks remain. Mortality is relatively low, ranging from 5 to 10%, yet long-term outcomes vary widely, depending on tumor location and surgical impact on critical brain structures. Survival at 5 years is reported between 55 and 85%, reflecting differences in patient age, tumor subtype, and completeness of resection. Long-term morbidity is often linked to injury of the hypothalamus, a region that controls appetite, energy balance, and hormone regulation. Studies report that roughly 56% of patients achieve a good outcome with preserved neurological and endocrine function, while about a third experience poor outcomes with significant lasting effects. Even among long-term survivors, complications can persist. Hormonal deficits are common, requiring ongoing replacement therapy.
Cognitive problems, such as difficulty with memory, attention, or planning, may appear gradually over time. Some patients also develop psychological disorders, including mood disturbances or anxiety, which can impact daily life and overall quality of living. Overall, while most patients survive and achieve meaningful recovery, careful follow-up is essential to identify and manage late complications and to maintain function in both physical and cognitive domains. Recurrence is a central problem in the management of craniopharyngioma. Even after treatment, the tumor can grow back because it lies next to critical brain structures where complete removal is sometimes unsafe. Recurrence is still common. Rates differ between age groups. In children, recurrence occurs in roughly 39% of cases, while in adults it is lower, around 22%. These numbers reflect the biological behavior of the tumor and the difficulty of achieving complete removal without injuring nearby structures, such as the hypothalamus or optic pathways. Treatment strategy strongly affects recurrence risk. When surgeons achieve gross total resection, meaning the entire visible tumor is removed, recurrence rates range widely from 0 up to about 50%, partly because microscopic tumor cells can remain hidden within surrounding tissue. A different pattern appears when only part of the tumor is removed. Subtotal resection leaves residual tumor intentionally to protect nearby structures, yet recurrence rates in this setting may rise from roughly 25% to nearly 100%, depending on the amount of tumor left behind. This difference matters clinically. Radiotherapy helps control this remaining disease. When subtotal resection is performed alone, recurrence may occur in more than half of patients, but when postoperative radiotherapy is added, recurrence rates can fall dramatically to roughly 0 to 20%, showing how combined therapy improves long-term tumor control.
Craniopharyngioma is a benign tumor, but it can be locally aggressive because of its position next to the pituitary gland and surrounding brain structures. Despite being non-cancerous, its growth can cause pressure on the brain, vision problems, and hormonal imbalances, which often drive the clinical presentation. The tumor shows a bimodal age pattern, appearing most commonly in children and then again in adults. The Adamantinomatous type is typically seen in children, characterized by cystic components and calcifications, while the Papillary type is more frequent in adults and usually appears as a solid mass. Understanding the subtype helps guide treatment and follow-up planning. Surgery remains the mainstay of treatment, aiming to remove as much of the tumor as safely possible. Radiotherapy is often used when residual tumor remains or if recurrence occurs later. Because these tumors affect hormone production and vision, lifelong follow-up with endocrinology and ophthalmology is essential to detect complications and maintain quality of life. Thanks for watching this overview. For more high-yield neuroscience education and clinical tips, join the StudyNeuro community on YouTube, Facebook, TikTok, Instagram, or X. Like, comment, share, and subscribe to stay updated. Stay tuned for more insights in future videos.